professeur Raul GARILLO qui est un expert international sur la question. Et donc, la dernière fois, nous avions fait une session avec la syncope. Aujourd'hui, c'est autour de la fibrillation atriale, qui est un thème fédérateur. Donc, les diapositives seront en français. Lui, il va faire sa présentation en anglais. Et nous allons donc être le plus interactif possible et je ferai des synthèses donc, en fonction de là où se situe sa présentation. Donc, dans l'audience, je pense qu'il y a des cardiologues, mais aussi il y a des neurologues. Donc, c'est bon à savoir. Nous avons invité les neurologues parce que, concernant notamment les AVC cryptogéniques le plus souvent, donc il y a la fibrillation atriale en dessous. Alors, Raul, I think it was just to present the beginning of our session today and to tell that it is a pleasure for us to receive this presentation from yours because you are an international expert about rhythmologies, and we are very happy to talk about atrial fibrillation because atrial fibrillation is a big issue donc about rhythmology and about stroke, and that's why in the audience we will have colleagues is service with us and to talk about the cryptogenic strokes. And I think that I will let you to take the floor and to begin your presentation. And thank you very much, Professor Raul.
Thank you, dear colleagues. Thank you, Adama. Bonjour. Merci beaucoup pour l'invitation à participer pour la deuxième fois à ce forum. Aujourd'hui, nous allons parler de la fibrillation auriculaire sous ces deux aspects, l'arythmie et ses complications. Then, could we have our first slide, please? Okay. When we joined to all of you a couple of weeks ago, we were talking about syncope, and one of the first points that we were discussing was about the definition. And I believe that in medicine, definition is a very important part and must be the first part of any discussion. Then in this situation, let me ask you, how long-lasting an episode of atrial fibrillation, how long our atrial fibrillation must last to make the diagnosis of atrial fibrillation? Which is the time that we need in this arrhythmia to call it atrial fibrillation? Not for treating, but for the diagnosis of atrial fibrillation. Is 1 minute, 30 seconds, 10 minutes, 1 hour? Please vote about this, and then we will start to discuss atrial fibrillation. I'm ready to see what is your opinion. I'm eager to know your opinion.
OK. Alors, pour parler de fibrillation atriale, combien de temps une arythmie irrégulière dans l'oreille peut être considérée comme fibrillation atriale? La durée de cette arythmie au niveau de l'oreille, est-ce que c'est 1 minute, 30 secondes, 10 minutes ou 1 heure? Avant de le considérer comme significatif pour parler de fibrillation atriale. Voilà, c'est soumis au vote. Maintenant, on a 2 minutes pour voter, 45 secondes, and 44% has asked now.
Well, we are around 93. Then I need more people voting, please. Yeah. Then we can start to discuss.
OK, c'est anonymat, vous pouvez y aller, y a pas, on ne va pas vous démasquer. Hein?
You wanna hear it in the web, you wanna hear it in the TV. It's a private decision. Nobody knows which are voting, what is they are voting. But it's important for us to know which is the opinion. Well, we have a 1.5 minutes is enough, and now we can see that they are not moving many numbers. Then we can stop here if you wish.
Okay.
Take a look that although there are a predominant 30 seconds as the definition for atrial fibrillation, still some of you have the opinion that is enough with 1 minute, other one 10 minutes, and few ask for 1 hour. Then, as you can see, it's necessary to have a definition because all of us will think in the same way. Could we move to our next slide, please, Sonia? Okay. If you move again, will appear a couple. Yeah. Okay. This is the right answer. The definition of atrial fibrillation. Once again, please click. Once again more. Okay. The definition is if you see a 12-lead electrocardiogram, a tracing of 30 seconds showing no P waves, 30 seconds of duration, and RR irregular, RR intervals irregular. With these 3 tools, you can be sure the diagnosis is atrial fibrillation, 30 seconds. It's a recommendation class 1, level of evidence B. It means really very high. Okay, we need to move to the next slide, please.
So if you permit, Professor Raul, before going to the next slide, about the confirmation of atrial fibrillation, the last recommendation talk about the tools, which is ECG. But we know that we have other tools like connecting system, like Apple Watch or something from Samsung. And if we have arrhythmia, rapid arrhythmia in the atrium, could we tell that it is atrial fibrillation, or we need to confirm with an ECG, like you say, 20, 30 seconds with an ECG? Because some tools give you almost perfect electrocardiogram. Yeah. What do you think?
You can find the same diagnosis by means of a Holter monitoring of the watch. Nowadays we have a watch. We will talk it about the end of this presentation. When you can prove that the arrhythmia is lasting 30 seconds, there are no P waves, and it's an irregular RR interval. With these 3 tools, you have the diagnosis of atrial fibrillation. That also can be recorded by the watch, or by the monitoring holder, or by the common classical electrocardiogram. Yeah. Okay.
Donc c'est vraiment important. It's a message. I tell it in French. So, si vous avez une arythmie qui est caractérisée par une absence d'onde P visible et des intervalles RR inéquidistants, donc qui ne sont pas réguliers, donc une irrégularité au niveau des intervalles RR, et cet événement-là dure 30 secondes, vous pouvez donc dire que vous êtes devant une fibrillation atriale, même si elle n'est pas soutenue, même si elle disparaît par la suite. Donc c'est ça la définition. Thank you.
Okay, move ahead, please. Next. When we have a definition of atrial fibrillation, now we must comment that there are different kinds of atrial fibrillations. Move to the next, please. The first one is the paroxystic atrial fibrillation. The definition of paroxystic atrial fibrillation is an episode of atrial fibrillation that lasts less than 1 week, appears suddenly, and go away suddenly too. It means that you don't need to take any decision, therapeutic decision, because disappear alone without medical therapy. This is the definition of paroxystic. Came suddenly and disappears suddenly without therapy, and lasts less than 1 week. Is it clear what is paroxystic? Any comments?
I think it is clear. Donc, fibrillation atriale paroxystique, c'est une fibrillation atriale qui dure moins d'une semaine. Donc, qui disparaît de manière spontanée, donc sans intervention, et qui ne dure pas une semaine. Si ça dépasse une semaine, ce n'est plus une fibrillation atriale paroxystique. Voilà. OK, moins d'une semaine.
Next. If we are talking about persistent atrial fibrillation, is an atrial fibrillation is a long-lasting persistent atrial fibrillation, is a persistent fibrillation that it will last more than 1 week, less than 1 year. Of course, once again, appears suddenly, but you need to treat if you want to put it far away of your patient. To put it out, you need to treat by means of any drugs or whatever. Then the difference is that it lasts more time and you need some therapy if you want to stop with the atrial fibrillation. Any question?
C'est clair, je pense. Si vous avez des questions, vous pouvez mettre ça dans le chat en attendant. Voilà.
Yeah, true. Next, please. Okay. This is the third kind of atrial fibrillation. It's the long-lasting, persistent atrial fibrillation. Once again, appear suddenly, and the duration is more than 1 year. More than 1 year. If you want to stop, you need to treat. Okay? Doubt about this?
Yeah. Okay.
Okay.
I could comment after the last one, and I will comment for the boss.
Okay. Okay. Next then. The last one is permanent atrial fibrillation. That means the patient has this kind of arrhythmia for many years, and then is last forever. This is the typical permanent atrial fibrillation, lasting forever. The patient will tell you that for many years he has the same arrhythmia. He has a lot of electrocardiograms for 3, 4, 5, 10 years ago, always with the atrial fibrillation. Yes, with this is the classification nowadays of atrial fibrillation. I know that you, Adama, want to make some comment to all together.
Yeah. En réalité, il y a 3 types de fibrillation atriale. Il y a la fibrillation atriale paroxystique qui dure 1 semaine et qui disparaît de manière spontanée en moins d'1 semaine, c'est-à-dire qui ne va pas durer au-delà d'1 semaine et qui disparaît spontanément. Si on a besoin d'agir dessus pour que ça s'arrête, ou si ça dépasse 1 semaine, c'est une fibrillation atriale persistante. Mais les fibrillations atriales persistantes, par définition, ils vont et ils viennent, mais ils ne dépassent pas 1 année. Si maintenant le patient a une fibrillation atriale paroxystique, persistante, qui vient, qui part, et qui a cet épisode-là qui est suivi comme ça pendant 1 année, ça va et ça revient. On parle de long-lasting, persistent atrial fibrillation, c'est-à-dire des fibrillations atriales persistantes de longue durée. Après, maintenant, il y a if you are with me, we can't tell that permanent atrial fibrillation is an accepted atrial fibrillation. We accept that the patient is in atrial fibrillation because he is patient. Donc la fibrillation permanente, c'est une fibrillation atriale qui est acceptée, c'est-à-dire que de toute façon, même si on l'arrête, elle risque de récidiver. C'est ce qu'on a, notamment chez nos valvulaires, etc., avec de la... Je pense que ça. Donc, par rapport à ça. Mais en gros, c'est vraiment ça la classification de la fibrillation atriale. OK.
Next, please. Well, up to now, we have the definition of atrial fibrillation and the different type of atrial fibrillation. The third point to discuss with you is there are many things happen related with atrial fibrillation. And we can resume in 3 points: risk of stroke, risk of cardiac insufficiency, heart failure due to the tachyarrhythmia, and third one, the presence of symptoms. The patient complains about symptoms. When a patient is arriving to your office, which of these 3 different problems is, from your point of view, the most important? The risk of vascular accident, stroke, the risk of cardiac insufficiency, or the risk of symptom, or the problem of the symptom? When you want to treat a patient, which is your main responsibility of the 3-1? I know that probably all of you are thinking the 3 are problems very serious. Yes, and I agree with all of you. But which is the main reason because you will treat the patient? The main reason among these 3. What do you think is the main reason to treat a patient? The risk of a stroke, the risk of cardiac insufficiency, or the symptoms that the patient are telling us? Okay, we will stop on 1 minute 30 seconds. We will stop our voting. Then still you have time. Five seconds, last chance to vote. Okay, this is what we have. Take a look what was the answer. For most of you, the therapy, the indication for therapy, the main reason is to avoid stroke. The second possibility is to prevent heart failure. And the last is to improve symptoms. However, in the clinical condition, our first responsibility is related to improve symptoms. I know that this is a very tough issue and is open to any kind of arguments, but when you take a look about all the information all over the world, you will see that most of the main centers and main guidelines in the world put the first responsibility in symptoms. The first that we have to treat is symptoms. After that, we need to evaluate the risk of stroke and the risk of heart failure that for sure could be present. But our first responsibility is to improve symptoms. Well, move to our next slide, please. Okay. Then, now we have two branches. I see one question that is, how can atrial fibrillation cause stroke? Well, we will develop this in 10 minutes, probably, okay? Hold the line, like the song, hold the line. Okay. We will arrive to that point. we have two branches. One is control of the arrhythmia. The other one is control the risk of a stroke. There are the two main branches in atrial fibrillation. If we want to treat the arrhythmia, we have two different ways. The first way is if we want to control the ventricular rate, because this is one of the most important parts of the atrial fibrillation, the acceleration, the speed up of the ventricular due to atrial fibrillation. Then, one possibility to treat atrial fibrillation is to control the rate, the ventricular rate. The other one is control the rhythm. It means that we try to regain sinus rhythm like it was before when I was a healthy man. And the other part is the stroke, where we'll discuss the anticoagulation. Then, my suggestion is move to our first problem, control of the arrhythmia. Next slide, please. Okay. We can control the frequency, the rate, by means of different instruments. If we want to control the ventricular rate, you can treat your patient with drugs that depends on the ejection fraction. If the patient has a normal ejection fraction or near normal, over 40% of the ejection fraction, you can apply beta blockers, calcium blockers, or digoxin. As you can see, in the left, we have a very fast atrial fibrillation. And after that, because drugs, take a look that the rate is diminishing, is decreasing. And this is because the effect of the drugs. But if the patient has a low ejection fraction, below 40, you still can use beta blockers or digoxin, but you cannot use calcium blockers. This is the recommendation of the guidelines. Finally, the third element is the possibility to diminish the ventricular rate by means of non-pharmacological therapy. That it means ablation of the AV node. This is cut the connection in between the atrial and the ventricle. Of course, when you apply this kind of therapy, AV node ablation, you need to implant a pacemaker to be sure that you will have a right rate in the ventricle due to the pacemaker. But if you choose to regain sinus rhythm, you want to return to sinus rhythm, then you have another tools that you can see at the bottom, drugs, cardioversion, and the electrocardiogram. You can see that's example, cardioversion shock and return to normal sinus rhythm. Or the most important tool nowadays is the ablation by means of a catheter. We will talk about these 3 points. Now, the question is, when I have to choose, next, please. Next. Okay. If you want to return, to regain sinus rhythm, there are different clinical pictures that you will face. For instance, in the left of the slide, you will see people with no signs or minimal signs of structural heart disease. Then you can offer a patient 2 possibilities: therapy by means of drugs, dronedarone, flecainide, propafenone, or sotalol, or you can offer to your patient the catheter ablation. It's an indication 2A, level of evidence B. This is a very well-known level of information. If the patient is in the middle of this slide in red, if the patient has a coronary artery disease, or if the patient has a significant valvular heart disease, or if the patient has an abnormal left ventricular hypertrophy, once again, you can choose, you can offer your patient, please, 2 possibilities. Drugs therapy, dronedarone, sotalol, there are an amiodarone, or once again, you can offer a catheter ablation. Once again, it's a level of evidence, indication 2A, level of evidence B. And finally, if your patient has a clear heart failure, in that case, you can offer to your patient the possibility of treating by drugs, in this case with amiodarone exclusively, or once again, catheter ablation. Then, as you can see, when you choose to return to sinus rhythm, you need to take into account the clinical frame of your patient, the entire clinical picture, to choose the best way to return to sinus rhythm. Could we move to the next, please? Okay. When we are talking about rate control, or when we are talking about sinus rhythm recovered, which are the patients that fit in the possibility of ventricular rate control, and which are the patients who deserve to return to sinus rhythm? This is a very important question, and once again, it's a clinical question. As any other cardiology, I need to take into account many considerations before to choose if I will try to get sinus rhythm again, or I will decide to maintain an adequate ventricular rate. We could move to the next, please. Okay. When I will choose to maintain a good ventricular rate, but with atrial fibrillation, but protecting the ventricle with a good ventricular rate by means of drugs, by means of AV node ablation, in which kind of patient? All patients, first of all, with few symptoms or no symptoms, people who have recurrence of atrial fibrillation, over and over again, they return to atrial fibrillation, or people when I fail to obtain sinus rhythm by means of drugs, the drug doesn't work, and the patient is still with atrial fibrillation, or if I see that the left atrial is a large atrial, more than 45 millimeters, it means it's a very large. In that case, probably I won't get sinus rhythm again. And the only thing I can do is to maintain an acceptable ventricular rate. Move to the next slide, please. On the other hand, when I will choose to obtain once again sinus rhythm, first of all, if the patient asks for it, I don't care, doctor, do what you have to do. I want to return to sinus rhythm. Okay, this is one possibility that I will choose, because I will choose sinus control of the rhythm. Excuse me, control of the rhythm. The second, if it is a young people, very active, they need sinus rhythm, and I will try to get for them sinus rhythm. The third point is the people is very symptomatic. It's all the time feeling that the heart is not working properly. They are not feeling well 24 hours per day. They need to return to sinus rhythm. The next point, if I was trying to control the ventricular rate, but I failed, then I will try to get once again sinus rhythm. The next is if I have dysfunction, ventricular dysfunction, and we are moving to the heart failure, then it's mandatory try to recover sinus rhythm. The other way is if the patient has a paroxystic or persistent, but recently appear for the first time, then it is a good probability to recover sinus rhythm. Or if the patient has a normal or small left atrial, this is a good indication for trying to recover sinus rhythm. Or if I see that my patient has an acute atrial fibrillation, recently appeared, never appeared before, this is the first time, well, this is a good opportunity to recover sinus rhythm. Also, if the first episode of atrial fibrillation that I can prove this patient suffered, never before. And finally, if the atrial fibrillation is related to a reversible cause, like, for instance, alcohol or any other drugs, then it's a good opportunity to try to return to sinus rhythm. As you can see, we have two possibilities to choose: ventricular rate control or rhythm control. And this is depend not only of the arrhythmia, depends on the complete clinical situation. We are doctors, but we need to see we are cardiologists, but we need to see the entire picture, not only some small details. Okay, any comment, Adama, that you would like to add?
Yeah, I think it is very, very important, this approach about the management of atrial fibrillation. Je pense que c'est extrêmement important parce que, comme il l'a dit, déjà au début, lorsqu'il y a eu une question sur ce qui motive pour aller au traitement, beaucoup de gens ont dit que c'est pour prévenir donc la fibrillation atriale. Alors que dans les questions, il y a les symptômes. Est-ce qu'il faut regarder les symptômes avant de traiter? Donc, les symptômes, c'est fondamental puisque c'est ce qui fait que le malade quitte chez lui pour venir à l'hôpital. Donc, il vient avec une plainte. Et cette plainte-là, si vous ne réglez pas ça, donc de toute façon, vous pouvez faire toutes les manœuvres de prévention, mais le patient risque de ne pas adhérer et ça risque de ne pas être efficace. Donc, les symptômes, c'est vraiment ce qui va donc guider la prise en charge de la fibrillation atriale. Et donc, dans la stratégie de prise en charge, il y a le traitement antiarythmique, mais aussi le traitement anticoagulant. Donc là, on est en train de voir le traitement antiarythmique et il y a deux options. Soit on part dans l'option de rendre le rythme sinusal, donc de dire que c'est un rythme sinusal, ce qui est affiché ici, c'est le contrôle du rythme, ou bien on dit qu'on va rendre la fibrillation atriale acceptable en réduisant la fréquence donc cardiaque de réponse, la fréquence ventriculaire moyenne. Et donc ça, c'est ce qu'on appelle le contrôle de fréquence. Donc, quand est-ce qu'il faut choisir l'un par rapport à l'autre? C'est ce qu'il est en train de développer. Et je pense par rapport au contrôle de la fréquence, ce qu'on a vu avant ça, l'âge est important. Si la personne est très âgée, donc il ne faut pas s'acharner à restaurer un rythme sinusal. De toute façon, on risque de ne pas y arriver. Si donc il y a eu un échec des antiarythmiques avant, donc ça risque de ne pas marcher. Donc on va être délétère, on ne va pas être efficace. Donc on peut se contenter de réduire la fréquence cardiaque uniquement. Lorsqu'il y a une récurrence importante, notamment dans les fibrillations atriales acceptées ou permanentes, là aussi, on ne pourra pas restaurer un rythme sinusal. Donc l'objectif, le challenge, c'est de maintenir une fréquence ventriculaire acceptable. Lorsque l'oreillette est très dilatée, donc lorsqu'on a une dilatation importante des oreillettes, un remodelage important, là aussi, on ne va pas y arriver. Donc le challenge sera de réduire la fréquence cardiaque et de rendre la fibrillation atriale acceptable, c'est-à-dire tolérable. Maintenant, il y a d'autres situations où il faut tout faire pour arrêter la fibrillation atriale. Parce qu'on sait que atrial fibrillation lead to atrial fibrillation. C'est-à-dire si la fibrillation atriale démarre maintenant, donc ça vient de démarrer, les oreilles ne sont pas remodelées, la personne n'est pas très âgée, lui-même il est demandeur, il y a une tachycardiomyopathie donc qu'on suspecte. Donc dans ces conditions-là, il faut tout faire pour restaurer un rythme sinusal. Donc la restauration de ce rythme sinusal-là sera même bénéfique pour l'avenir rythmologique donc, de ce patient-là. Donc, en fait, c'est là où on en est par rapport à la présentation. Thank you very much, Raul. I have done a brief summary.
Yeah, I heard. Yeah. I'm improving my French.
French, yeah.
My French, yeah, I'm improving. Next one, please. Okay. One of the questions that I want to discuss with you is where the atrial fibrillation begins. Where the atrial fibrillation begins inside the atrial, in which part of the atrial fibrillation appears first. And we have different possibilities. The free wall of the right atrial, the interauricular septum, the pulmonary vein, the cave vein, or the appendage of the left atrial. Then tell me, what do you think? Which is the beginning? Which is the site for the most common site for beginning the atrial fibrillation? Now we have the opportunity to vote. Okay. You have 1 minute and 30 seconds to choose what you think is the most common place to start the atrial fibrillation episode. I am expecting that all of you will vote, please.
Allez-y, c'est anonyme. Il faut voter.
Once again, it's anonymous. I'm voting too.
Okay, exactly.
Because it's anonymous. Oh, few people. I need more opinions. This is the opportunity to tell me what you think about it. Go ahead, please, vote.
Alors, la question, c'est où est-ce que la fibrillation atriale prend origine dans les oreillettes? Donc, est-ce que c'est au niveau de la paroi libre, du septum, des veines pulmonaires, la veine cave et l'appendice? Donc, vous pouvez voter. Là, on a 78. Yeah.
We are finishing. Okay, that's time. Okay. As you can see, once again, like in the definition, there are different opinions. And this is important because this is one meeting, this is our meeting to exchange ideas to obtain information, to improve our knowledge, and to become more and more efficient doctors. And this is what, because I want to be here, also I want to improve, exchanging ideas with all of you. As you can see, the most voted possibility was pulmonary veins. If half of all the people who have voted have chosen pulmonary veins. Also, another thing that in the free wall of the right atrium, some in the interatrial septum, and in the appendage of the left atrial. Well, we need to move to our next slide, please. Okay. In 1998, it means at the end of the last century, for the first time, someone showed us that most of the time, the atrial fibrillation begins in the pulmonary veins. As you can see in this picture, most of them start around the pulmonary veins, few cases in the right atrial or in the posterior wall of the left atrial. It means that most of the time, atrial fibrillation begins in the union of the pulmonary veins and the posterior wall of the left atrial. Why? The arrhythmias start there, because this is an interface, is the connection in between the venous tissue and the muscle of the atrial. And in this combination, exists the possibility to start with re-entry tachycardia that will degenerate development at the end, atrial fibrillation. And this is what Dr. Heisaguer in France showed us where the atrial fibrillation begins and how we can try this. And the solution for this was the ablation. What means ablation nowadays is the disconnection, electrical disconnection, not anatomical, but electrical disconnection of the pulmonary veins and the left atrial. Then, by means of this ablation, we can avoid the atrial fibrillation in most of the times. And this was a fantastic step forward ahead to offer an attractive solution for a very, very important arrhythmia like is atrial fibrillation, and like Dr. Adama said at the beginning, is the most popular, the most common arrhythmia in the heart if left is atrial fibrillation. Now we know that it's coming from pulmonary veins, and now we know that most of the time we can disconnect electrical disconnection in between pulmonary veins and left atrial. We can do it by two ways. By heart, there is a radio frequency ablation to the top and the left of this slide, or by cold. This is a cryoablation that is nowadays most popular because it's easier to handle and with a short procedure instead of radio frequency that is a very prolonged procedure. But in both cases, they had very good results with ablation. Next slide, please. Related to this possibility, when we want to recover sinus rhythm, that is the most important step, the indication nowadays is, as you can see in this slide. The first indication is symptomatic atrial fibrillation, refractory or intolerant to at least class 1 or 3 antiarrhythmic medication, then the guidelines recommend catheter ablation. If you see that, you can observe that the first indication to recover sinus rhythm nowadays is still drugs. And if you fail with drugs, you can move to catheter ablation in a class 1 level of evidence A, very, very high. But on the other way, you can choose ablation as the first step to treat atrial fibrillation. You can do that. It's a symptomatic atrial fibrillation in red, down, symptomatic atrial fibrillation prior to initiation of any antiarrhythmic therapy, you choose catheter ablation. It's an indication 2A level of evidence B. It's good. Not as good as the other one, but it's good. But in the near future, you will see that indication of first election to treat atrial fibrillation will be catheter ablation. Nowadays, still drugs first and later atrial fibrillation if you don't have success with drugs. But in the near future, the first indication, because there are more and more clinical evidence, in the near future, the first indication will be catheter ablation. Any comment, Adama?
Yeah. I think to summarize what you talk about, c'est dans les stratégies de restaurer un rythme sinusal. Il y a les médicaments, mais aussi il y a le traitement interventionnel. Donc, c'est l'ablation par radiofréquence. Bon, avant d'aller à l'ablation, il faut d'abord savoir quels sont les éléments à l'intérieur des oreilles qui déchargent et qui entraînent la fibrillation atriale. Donc, Heidegger a théorisé que le plus souvent, c'est au niveau, autour des ossia, des veines pulmonaires, que tournent des rotors, donc qui vont entraîner la fibrillation atriale. Et donc, ces arythmies-là, ces circuits, c'est des circuits d'arythmie de réentrée, ces microcircuits-là sont là-bas parce que tout simplement, c'est un lieu où donc le système veineux va se connecter avec le système atrial. Et donc, c'est deux tissus qui sont un peu différents et qui peuvent être le siège d'ouverture de ces arythmies-là lorsqu'il y a un certain nombre de situations qui le permettent. Et donc, c'est ce qui est à l'origine maintenant de la prise en charge, puisqu'on sait que c'est au niveau des ossia, des veines pulmonaires, que tournent les arythmies qui conduisent la fibrillation atriale. Alors, ce qu'il faut faire, c'est de déconnecter électriquement ces zones-là, donc de déconnecter les veines pulmonaires des oreillettes. Et comment le faire? Il y a deux systèmes. Il y a le système avec l'ablation avec le chaud, c'est ce qu'on appelle l'ablation par radiofréquence, comme il l'a montré. C'est une ablation point par point au niveau des ossia des veines pulmonaires jusqu'à créer une déconnexion électrique entre les veines pulmonaires et l'atrium et l'oreillette gauche. Il y a un autre système qui est plus simple et qui fait une ablation globale. C'est l'ablation en utilisant le froid, c'est ce qu'on appelle la cryoablation. Et donc, dans certaines indications, comme vous le voyez ici sur cette diapositive, on peut aller d'emblée à l'ablation avant même d'essayer un traitement médical. Donc, on a le droit, c'est une indication de classe 1, donc on peut y aller d'emblée sans même essayer un traitement antiarythmique. Et ça donne d'excellents résultats dans certains types de fibrillation atriale. Voilà. OK. I think we got...
Okay. Then we can move to our next slide, please. Well, now we are talking about the second part. We were talking about how to control the arrhythmia. Now we will talk about anticoagulation. We move to our next slide, please. Okay. Any patient with atrial fibrillation have a risk of thrombo-embolic episode and develop a stroke. how we measure the risk. We measure the risk by means of a risk criteria and score. This score have points for each of these different issues. 1 point for congestive heart failure, 1 point for hypertension, 2 points if the patient is 75 years old or older, 1 point for diabetes, 2 points if the patient has antecedents of stroke, transient ischemic attack, or thrombo-embolique event, 1 point if has vascular disease, 1 point if the age is in between 65 and 74, and 1 point if the patient is a female. These are the criteria of risk in this score. Could we move to the next, please? Okay. If you have a CHA2DS2-VASc of 0, the stroke of risk during 1 year, the next year, is 0. If you have 1 risk factors, any, the risk 1 point, the risk will be 1.3. If you have 2, will 2.2. If you have 3, 3.2. If you have 4, is 4 also. The risk of a stroke, 4% of this patient will develop a stroke during 1 year. If you have 5, 6.7, so on, until the highest is 9 risk factor, is 15.2. Then, now, if you are following this CHA2DS2-VASc score, you can value the risk of your patient to have a stroke in the next 12 months or in the next year. Next, please. Okay. If your patient have a CHA2DS2-VASc score of 0, the recommendation for anticoagulation is known. We don't need any anticoagulation therapy. If the patient has 2 or more, at the bottom of the slide, they need for sure oral anticoagulation. And as you always see in medicine, if you are in the middle, in the gray zone, you have only 1 risk factors, the decision could be not therapy at all, or aspirin, or oral anticoagulants. As you can see, in this situation, always is difficult to take the right decision. And there are many different opinions among the guidelines and among the Society of Cardiologists all over the world. Next, please. I want to ask you, according to what we have seen in the last 2 slides, which is the score of this patient. Is a patient male, 59 years old, antecedents of a stroke and with diabetes, which is the score of risk of thromboembolic episode for this patient. Could we vote, please?
Donc, il a 59 ans, il a des antécédents d'AVC, il est diabétique. Et c'est un homme. Donc, quel est son score de CHA2DS2-VASc? Est-ce que c'est 2, 5, 3 ou 4?
Okay, we have 1 minute and 30 seconds to vote. Few people are voting. What is going on with the rest of the people? I'm eager to know the opinion of all of you, not some of you, all of you.
50%.
20 seconds to have the decision. Please vote. I need more opinions. 5 points. 8. 4 points, 3 points. Okay. Okay, it's time to stop. Perfect. Okay, take a look at 60% of you, their opinion was 3 points, 22% 2 points, 6% 5 points, and 12% 4 points. Take a look together. To be a male is not a risk factor. If you are below 65, once again, it's no risk factor. Then you have antecedent of a stroke. Stroke means 2 points, and antecedent of diabetes, that is 1 point. Then the right answer is 3 points. These patients have 3 points. That is enough to prescribe anticoagulation. But the real situation is that these patients have 3 points, not 2, not 5, not 4, 3 points. Remember, once again, stroke is 2 points and diabetes is 1 point. To be a man is not a risk factor, and to have 59 years old also is not a risk factor. Okay, let's go. Go ahead. When we are talking about the gray zone, we were talking patient with 0 risk factor, they don't need anticoagulation. People with 2 or more risk factor, they need anticoagulation. But people who has only 1 risk factors, if it's a man, or 2 risk factor, if it's a female, then what happened with them? Well, the first thing that we must assume is that not all the risk factors have the same importance. The importance could be different. For instance, you can see people in between 65 and 74 has a range of episodes of 3.5, but people who has a vascular disease have 1.9. Then it's different depending on which is the risk factor that is present. Why we show this slide? Because sometimes this slide could help us in a patient that has only 1 risk factor, but it's only 1, but it's a very heavy risk factor. And in other situations, could be a risk factor that is not so serious. Then I have the possibility to take the best decision for my patient. Move to our next slide, please. But if I still have doubts, I can see this risk supplementary that can help me to take the decision if I have doubt, if I need to anticoagulation procedure or not in a patient, in any patient. If the patient has a known paroxystic atrial fibrillation, the heart ratio is 1.35. In other words, it's 35% higher the risk of thrombo-embolic episode if the atrial fibrillation is a known paroxystic, meaning persistent, long-term persistent, or permanent. If the patient has a left atrial size over 45 millimeters, the risk is 1.92. It means 92% is 2 times the risk of a patient with normal atrial. Then it's another tool that can help me to have the final decision to perform anticoagulation or not in a patient. And finally, if the patient have high biomarkers, meaning proBNP, D-dimer, or troponins, the value, the risk increased from 1.22 to 4.16, meaning four times the risk that the people with normal biomarkers. Then this supplementary risk factor can help us to take the decision if we have doubt about anticoagulation or not for my patient. Is it clear? Adama, would you like to resume something?
Yeah, but it is very interesting to have this kind of additional criteria, because sometimes we have some problem to let the patient go without anticoagulation. I have some patients on me with Sixinus syndrome, and I think I know that the atrium are sick. You know, the atrium is not clean, and if I let him without anticoagulation, it can have a stroke problem, and the short VAS is not very high. You know, it is 0 or 1, and for this patient, it can have some problem to decide, and this kind of additional criteria could help. En fait, ce qu'il il y a le score de chaque VAS qui est un score qui est connu, hein, donc pour screener le risque thrombo-embolique des patients qui sont à fibrillation atriale. Je rappelle que ces critères, on les applique à des patients qui ont des non-valvular atrial fibrillation, c'est-à-dire des fibrillations atriales non valvulaires. Si on a une fibrillation atriale non valvulaire, pour évaluer le risque de faire un AVC, un risque thrombo-embolique, il faut évaluer le score de Schatz-Vasc. C'est C comme cardiopathie, H comme hypertension artérielle, A comme âge, 75 ans, et D comme diabète, S comme stroke et atteinte vasculaire. Donc, si plus le score de Schatz-Vasc est élevé, plus le risque de faire un accident donc thrombo-embolique est élevé. Mais en dehors de ces critères-là, il y a une zone grise. Une zone grise, c'est des patients qui ont un score de Schatz-Vasc à 1 et qui sont en fibrillation atriale, ou bien des patientes, donc c'est-à-dire une femme qui a un score de Schatz à 2, puisque le fait d'être femme déjà, on est à 1. Donc s'il y a un autre risque additionnel, on est déjà à 2. Et donc ça équivaut à un homme qui a un score de Schatz-Vasc à 1. Et donc chez ces personnes-là, c'est une zone grise, on ne sait pas trop qu'est-ce qu'il faut mettre, et là on peut céder de ces éléments-là. Le fait que si c'est une fibrillation qui n'est pas paroxystique, le risque est là, donc il faut peut-être mettre. Si le diamètre de l'oreille gauche est supérieur à 45 mm, c'est un critère supplémentaire qui n'est pas dans le score de Schatz-Vasc, mais qu'il faut prendre en compte. S'il y a une augmentation des marqueurs myocardiques et donc des marqueurs de fibrose là aussi, il faut donc penser à mettre, puisque c'est un risque supplémentaire. Donc voilà un peu donc de ce dont il était en train de parler. Voilà. Ok, Raoul.
Okay, move ahead with the next, please. Okay, this is a resume the different situation. Patient with non-valvular atrial fibrillation, and we can calculate the CHA2DS2-VASc score. If the patient has 0 or 1 because it's a female, no antithrombotic therapy is recommended. If the patient has 1 risk factor or 2 if a female, oral anticoagulation should be considered. There is a possibility. And once again, you can remember what we have talking right now. If the patient has 2 or more is a male, or 3 or more a female, clearly you need anticoagulant therapy. But if there is any contraindication for oral anticoagulants, we need to consider an atrial appendage occluder that we will talk at the end of this presentation in a few minutes. is another possibility in case you can apply oral anticoagulant because any disease of the patient that or the liver problem, then the patient have difficult for receive oral anticoagulant. Next, please. Okay, there is a situation that is very often in our office when we're receiving patient, and probably I think that you pass for the same problem like I'm passing every week in the hospital, at the hospital. Next, please. What happens if you discover that the patient has a completely asymptomatic atrial fibrillation? The patient didn't know that they have an arrhythmia. He came to my office just for control, and I accidentally, I discovered that the patient has atrial fibrillation. Which will be my conduct? What I have to do? Well, if I discover that the atrial fibrillation is asymptomatic more than 24 hours, I need to perform the CHA2DS2-VASc score, and if the CHA2DS2-VASc score is positive, I will indicate anticoagulation. Although the patient is asymptomatic, anyway, they deserve anticoagulation protection. If the patient has an atrial fibrillation that lasts less than 5 minutes, it's a very short episode, the patient doesn't need anticoagulation. This kind of patients doesn't need anticoagulation. And once again, we need to move to the gray zone. What happens if the patient has an atrial fibrillation that lasts more than 5 minutes, but less than 24 hours? What should I do? Okay, we need to move to our next slide, please. In a classical paper published some years ago, the ASSERT study, the patient who has a score of 3 or 4 get benefit from the anticoagulation if the atrial fibrillation lasts in between 6 minutes and 24 hours. Once again, then for this gray zone means more than 5 minutes, less than 24 hours, what should I do? Well, if the patient has a score of 3 or 4, they will get benefit of anticoagulation. If they have a score below 3, they don't need anticoagulation therapy if the atrial fibrillation lasts in between 6 minutes and 24 hours. Next, please. There is an opportunity to use antiplatelets or aspirin or something like this. When I need to think in this kind of drugs. There is a triple therapy. This triple therapy means oral anticoagulant, aspirin, and antiplatelets like clopidogrel or prasugrel. Well, the only indication nowadays for this is patient who has a percutaneous coronary intervention procedure and receive an stents for an artery coronary disease. In this situation, anticoagulation plus aspirin plus antiplatelet like clopidogrel is indicated. This is nowadays the only indication for combined triple therapy. Next, please. Okay, it's time for a new questions. And I expect that in this case, everybody will vote. It's a male, 65 years old. He has palpitation without antecedents, suddenly appeared palpitation. I performed an electrocardiogram that was completely normal. The patient has a story of hypertension, not very serious. And pro-BNP show 460 picogram per milliliter. And I indicate a Holter monitoring for 24 hours. And the result was that I saw a 1 minute atrial fibrillation episode, and later in the same day, 2 hours of atrial fibrillation. Under these circumstances, which is the right behavior for me with my patient? Antiplatelet only, anticoagulants, oral anticoagulants, no treatment for now, or to repeat the Holter monitoring, which should be the right or the best behavior in this case. Time to vote. Okay, you have 1 minute, 30 seconds. I expect to receive all of your opinions. I need all of your opinions. Remember that the age of this patient is 65, not 66, 56. It's 65, 65. This is it's a wrong number here in the voting paper. Is 65 years old.
Ok, c'est bien 65 ans et non 56 ans.
Eight antiplatelet. We are 5 seconds until the end of the voting procedure. Okay, it's time. Okay, it's time. Most of you have voted oral anticoagulant. Some of you, 11%, the indication was no treatment. Another Holter, 6%, and antiplatelet, 13%. If we take into account what we call the risk factor, the patient has, one is the age, 1 point over 64. The second point is hypertension. The 3 point is heart failure, because this patient has a pro-BNP of 460. The top normal top level is 300, and the patient is over. It meaning that although he has no many symptoms, he has some degree of heart failure. Then at the end of the day, this patient have 3 points of the CHADVAS score. For that situation, he deserves, as most of you have the same opinion, 70%, they must receive oral anticoagulant therapy. Very good, excellent. Okay, any comment, Adam, or can we move to the last couple of?
Yeah, I think it is clear. This, just to summarize, puisque ici, il s'agit de patients qui ont une fibrillation atriale qui n'est pas soutenue et qu'on retrouve au niveau du Holter. Le problème, c'est le timing, c'est-à-dire si ça fait moins de 5 minutes, c'est clair. Le plus souvent, il ne faut pas trop les considérer. Si ça fait plus de 24 heures, c'est clair, il faut anticoaguler. Entre les deux, il y a une zone grise. Et donc, c'est pour cela qu'il a parlé de l'étude de SR qui dit que lorsqu'on dépasse 6 minutes, entre 6 minutes et 24 heures, si on regarde si le malade est éligible pour un traitement anticoagulant, comme le stipule le score de Schatzvask, il faudra mettre le traitement anticoagulant et considéré comme une fibrillation atriale. Mais vous êtes d'accord avec moi que c'est pas la question ne se poserait pas si, par exemple, c'est quelqu'un qui a un AVC, chez qui on demande un Holter, on tombe sur un lambeau de fibrillation atriale, là, quel que soit le timing, on peut effectivement initier donc le traitement anticoagulant. Voilà, en gros, c'est ça. Thank you.
Okay, I have a couple of slides at the end of this meeting. Next, please. We were talking about the appendage occluder. Sometimes with some problems in blood coagulation, they don't deserve, they cannot receive oral anticoagulation. In that case, we know that 98% of the thrombus appear in the appendage of the left atrium. This is the place where all the thrombus appear. Then we can use, next please, an occluder to block the thrombus inside. When we can't perform ablation because the patient has problem with the anticoagulation, next please, we can apply this occluder that block the appendage, the left appendage, and avoid that the thrombus move from that place to the circulation and to the brain, just in case. Then this is an instrument that we can think when the patient has problem with the anticoagulation therapy. Next, please. With Dr. Adama, we were talking a few minutes ago about the possibility to discover atrial fibrillation, not only by the electrocardiogram, but by means of different instruments, a long monitoring procedure in the right, or a very simple horloge, a clock that offered to us the possibility to record the electrocardiogram at any time, and I can storage. I can put all this information that is inside of the clock to my computer, and then my doctor will discover that I have some minutes, hours, or whatever of atrial fibrillation along the day, or during exercise, or during the repose, or in the night, or in the morning. And at the end, it's a very, very important instrument. It's more popular. Each day is more and more popular to discover this this very serious arrhythmia that is the atrial fibrillation. Then, up to now, we review in a very brief way, in a very fast way, the possibilities of atrial fibrillation. I would like to finish this meeting with you with the final question, and to receive your voting for the final question. Could we move to our last slide, please? Okay, it's very simple. There are two patients, one male, one female, different risk factor. Could you tell me which has the highest risk for thrombo-embolic episode, please? Okay, we still have time. I need more people voting, please. Go on. It is the last. It's just to say goodbye. It's the last voting. Put all your effort. Okay. 20 seconds, last chance to give me your opinion. Okay. 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 Stop. 86%, the vote was the female, and 14% the vote was for the male. Take a look what happened here. The lady means 1 point. 67 is another point, 2 points. The stroke episode is 2 points more, mean 4, and the diabetes is 1 point, is 5 at the end. The risk is 5. The man, to be a male, is no risk factor. 2 points because he's older than 75. 2, hypertension, 3, and cardiac insufficient, heart failure, 4. This means 4 risk factor against 5-point risk factor. Most of you were right. The people with highest risk factor was the woman, although both deserve an oral anticoagulation. Thank you so much for participating. Please, could we move to my last slide, please? Thank you so much. I hope that could be useful for you. For me, it was a fantastic time sharing with all of you. Thank you so much, and to give me the opportunity to exchange comments and knowledge with all of you from this faraway country, Argentina in South America. Thank you so very much. Thank you, Adama. Thank you, Sonia. Thank you so much, all of you.
Yeah, thank you very much. Thank you very much. I think it is a pleasure for us to have this session, very interesting, and the agents, about the agents, you see there are many people since 2 hours following this session. It's a very interesting one. So we have some questions in the chat. Very quickly, if we can answer one of them.
Yes, of course.
It's Youssef who talk about the etiology of atrial fibrillation. I think the etiology, the most etiology that we found here is hypertension. Hypertension in the adult lead to atrial fibrillation. And for the young people here in Africa, we have rheumatic heart disease, which is a big etiology of
but it's a valvular heart disease.
Valvular, yes, it's a valvular.
Secondary to a valvular heart, mitral valve disease.
Mitral, yeah, exactly.
Yeah.
So, if you have a comment,
I agree with you. Probably you mentioned hypertension. The point is, atrial fibrillation need a fibrosis procedure. Yeah. Any disease that promote fibrosis procedure
can lead
is announcing the possibility to develop in the near future atrial fibrillation. Exactly. The enlargement of the left atrial for any cause, most of the time because coronary artery disease, or because the rheumatic fever, or because hypertension promote fibrosis. When you get a lot of fibrosis, overall in the connection in between pulmonary veins and the posterior wall of the left atrial, you are opening the door to the procedure of re-entry arrhythmias and development later atrial fibrillation. This is the most common cause. Nowadays, by magnetic resonance study, you can value, and also with echo, the amount of fibrosis, and value the risk of developing atrial fibrillation. This is what we are advancing, and it's very attractive future in this issue.
Remodulation, exactly. So, Dank Pharma talk about the question about what going on with paroxysmal atrial fibrillation, because it is spontaneously regress. Is it worthwhile giving a treatment for the paroxysmal atrial fibrillation? But I think you have answered during your course, because atrial fibrillation lead to atrial fibrillation. If you don't stop the paroxysmal atrial fibrillation, it could lead to the remodelage to the fibrosis and become permanent or persistent. So I think it is yes, it is an issue.
One of the effects of the atrial fibrillation, one of the effects is that the refractory period is shorter, and while the refractory period is shorter and shorter, you are given more opportunity to sustain the atrial fibrillation. More time lasts the atrial fibrillation, more shorter is the refractory period, more chances to develop a permanent, persistent, or permanent atrial fibrillation. Sometimes, although paroxystic atrial fibrillation means that you can last until 5 or 6 days, sometimes the doctor treat this paroxystica because they want to cut the opportunity to develop later a persistent atrial fibrillation. Yeah,
exactly.
True.
So one question from Jian Ziati: are the guidelines the same for post-operative atrial fibrillation? Post-operative, perhaps it is. I don't know what operation is it.
Operation means ablation.
Valvular? Yeah. So
maybe you are, the doctor is referring to ablation. Yeah, it's an interesting point. When you perform an ablation and you recover sinus rhythm, the question is, this patient was under anticoagulant therapy. Now that I restore the sinus rhythm, should I stop with anticoagulants? Most of the physicians wait until at least 3 to 6 months. And if the patient is still with sinus rhythm, some of them stop with the anticoagulation. But let me tell you that most of the time they maintain anyway anticoagulation. Some physicians that are very, very well known, that for instance, Dr. Baranchuk in Canada, he demonstrates that performing Holter monitoring for many, many times in patients that receive ablation, in the long time, most of them has few short episodes of atrial fibrillation that are asymptomatic. Then the people, he don't know or she don't know, doesn't know, and the doctor also don't know that the people are again with atrial fibrillation. This is the reason, because most of the physicians, the preference is to maintain an oral anticoagulation. Yeah.
Yes, and most if the Schwarz-Watz score is very high, I think it is more prudent to maintain. The last question is from Abdul Wahab Karimu. Talk about the choice criteria to ablation. I think it is paroxysmal atrial fibrillation and no good response. And persistent. And no good response of the drugs, of anti-arrhythmia drugs. So
right. So, the first choice for ablation always is paroxystic atrial fibrillation, because you have the highest chances to recover sinus rhythm. If you have a persistent, still you can try with less success, but still you can try in any way. There are, but the main indication clearly is paroxysmal atrial fibrillation. Yeah.
Okay. Thank you. I think it was this question. I'm going to do a rapid summary in French for the colleagues. Je pense qu'on a vraiment assisté à une session très intéressante et je pense que vous avez été très nombreux à nous suivre aujourd'hui. Et c'est très important puisqu'on parle de la fibrillation atriale qui est un thème fédérateur parce qu'en tant que médecin, tout simplement, on sera confronté à prendre en charge cette arythmie-là qui est l'arythmie la plus fréquente dans le monde. Donc, le docteur Raoul nous a rappelé la définition donc avec les éléments de définition pour dire qu'il faut 30 secondes quand même d'arythmie au niveau à l'étage atrial avec une réponse ventriculaire irrégulière pour dire qu'il y a une fibrillation atriale. Ensuite, il y a eu la classification avec les 3 formes qu'on connaît, la fibrillation atriale paroxystique, persistante, où on retrouve aussi la persistante de longue durée. Ensuite, la fibrillation atriale permanente. Et ces différents types de fibrillation ont un soubassement un peu différent parce que le substrat est différent. Dans la fibrillation atriale paroxystique, le plus souvent, il n'y a pas de substrat très important. Donc, on peut agir dessus, on peut proposer l'ablation qui va être efficace à long terme. Dans la fibrillation atriale permanente, c'est un problème de substrat. Et là, c'est d'autres considérations. Il faut traiter le substrat arythmogène. Entre les deux, il y a la fibrillation atriale paroxystique persistante qu'il faudra traiter. Ensuite, dans la prise en charge, il y a eu l'approche anti-arythmique et l'approche anticoagulante, antithrombotique. Dans l'approche anti-arythmique, il y a donc le fait de vouloir régulariser donc le rythme, de contrôler le rythme. Et l'autre option, c'est donc d'assurer une fréquence, une réponse ventriculaire acceptable pour le patient. Et donc, il y a plusieurs critères qui vont déterminer le choix d'une option par rapport à l'autre. Ensuite, il y a le traitement anticoagulant qui repose sur le score de Schatz-Vasque, qui peut parfois être pris à défaut dans la zone grise. Donc, c'est cette femme qui a un Schatz de score à 2, ou cet homme-là qui a un score de Schatz-Vasque à 2. Donc, on est un peu indécis. Et là, il y a d'autres critères additionnels qu'il a proposés donc pour faire le choix avant de mettre le patient sous anticoagulant ou pas. Donc, je pense faire comme résumé. Merci beaucoup.